Hi, good morning everyone. I'm Roshan Thapa, third year internal medicine resident at St. Joseph Hospital, Chicago. Today I have a very interesting case of purple globe syndrome, which is a rare complication of phenytoin. We had a 66-year-old bedbound female from nursing home with history of chronic encephalopathy and seizure. She was admitted to the ICU for management of status epilepticus. Initially in the emergency department, she was treated with benzodiazepine. She had a prolonged postictal stage, and due to lack of gag reflex, she was immediately intubated for airway protection. Her EEG revealed active epileptiform discharges. She was treated with her home medication in the IV form, which was IV levetiracetam and IV lacosamide. Due to the ongoing seizures, she was also started on IV phenytoin, which was given loading dose followed by the maintenance dose. All of her medication were given through right arm peripheral line. On day 2 of the admission, as you can see here in the picture, she started having edema of her hand. There were multiple flaccid bullae with skin excoriation over the site of peripheral line. Her edema gradually progressed up to the right arm. The blisters were bigger in size and eventually turned into purple bluish discoloration. Initially, immediately, all the IV antiepileptics were discontinued. Peripheral line was pulled out. They were concerned for Stevens-Johnson syndrome, so dermatology was consulted, who ruled it out, and also did through the shape biopsy. There was also concern for compartment syndrome, so ultrasound arterial and venous duplex of right upper extremity was done, which showed DVT of the brachial vein on the right side without the evidence of compartment syndrome. She was started on therapeutic anticoagulation. All of her IV antiepileptics were switched to oral, the equivalent doses, and also she had ongoing focal motor seizures, so midazolam drip was started through the another peripheral line on the left hand. Her blisters and the edema was treated with nitroglycerin cream for the prevention of the infection. Antibacterial cream was applied with gauze dressing and limb elevation. Her wounds gradually improved, and on day 15, as you can see here in the lower picture in the center, it has markedly improved. Her treatment course was prolonged by hypotensive events, failure to wean off her ventilator in the ICU, but after multiple EEGs, long ICU stay, the repeat EEG did not reveal further epileptiform activity. She was eventually extubated, transferred to tele unit, and then to the nursing home. So from my case, purple globe syndrome is characterized by pain, edema, and purple blue discoloration of the limb distal to the site of the phenytoin injection. It can evolve from a simple blister edema in our case, and sometimes can cause morbidity with compartment syndrome, critical limb ischemia. It is thought to be caused by the high alkalinity of sodium hydroxide alcohol and the propylene glycol content, which are both added in the phenytoin to increase its alkalinity and solubility respectively. The mainstay of the treatment is early recognition, immediate discontinuation of phenytoin, and limb elevation. Nitroglycerin cream and sometimes the brachial plexus block helps to reduce vasospasm and edema. The best way is to prevent it, and the prevention is very simple. We can use a large bore vein. While giving phenytoin, we need to use the correct dose and the correct rate, which is not more than 50 milligram per minute. And also flushing the IV line post infusion of the phenytoin with normal saline can prevent the purple globe syndrome. In conclusion, purple globe syndrome is one of the rare complications of phenytoin, and to reduce the morbidity related with it, early recognition and timely management and strong index of suspicion should be there. Thank you.